Good morning. You're now listening to Kingston Community Radio, airing on FM 92.5 and AM 920 WGHQ, Kingston, New York. This programming is brought to you by our listeners and corporate underwriters who are interested in presenting local community radio. The opinions expressed on this program do not represent those of Pamel Broadcasting or Kingston Community Radio. Listeners are encouraged to send in $10 per month to help bring this program to you. Mail your contributions to Kingston Community Radio, Post Office Box 4364, Kingston, New York 12402. For more information or to donate online, visit our website at mykcr.org. Good morning, this is Dan Gatis, and it is a Medical Monday. It's Monday, November 8th, and 30 degrees right now here in Uptown Kingston. We'll be right back after these messages.
A lot of talk about the COVID-19 vaccines, and everyone has an opinion. So I went to somebody I already trusted, my doctor. Talk to your doctor or healthcare provider and make the decision that's right for you. Go to getvaccineanswers.org for the latest information. Brought to you by the Ad Council.
If you came across someone struggling with hunger, how would you recognize them? By their clothes, their age, the way they speak? Would you notice a 16-year-old boy who got his first job?
Not for extra spending money, but to help feed his little sisters?
Or a mother who's in between jobs
and sometimes goes to bed hungry so her kids can have dinner?
Or a 14-year-old girl who signs up to every after-school activity
not to make friends, but just to get something to eat?
Or a retiree who fell ill and had to choose
between getting medicine or groceries.
I am the 1 in 8 Americans who struggle with hunger. People you pass by every day but never knew were hungry. I am hungered in America.
Hunger can be hard to recognize. Learn why at IamHungerInAmerica.org. Brought to you by Feeding America, 200 Food Banks Strong, and the Ad Council.
Hi, this is Cameron Rylance from Kingston, and I support Kingston Community Radio because it's informative.
Thank you, Cameron, and we'll do that for you. You're listening to KCR, Kingston Community Radio, WGHQ, AM 920 and 92.5 FM, and streaming online at mykcr.org. KCR's talk radio and a call-in show. Call in, 331-9255 is the call-in number. And today it's Eric Stamberg and Robin Baker for a Medical Monday. Let's see what the weather is going to be like for the next 3 days. Abundant sunshine today. That is good. A high of 61. Clear skies and a low near 35 tonight. And same tomorrow, except for a few afternoon clouds. It's going to be a lot of sunshine and a high of 61. And Tuesday night, cloudy with a low of 43. So we're not getting down that low on Tuesday night. Wednesday, again, a high of 61 with only a few passing clouds. Otherwise, sunny. And Wednesday night, a few clouds with a low of 31. Sounds good. Let's get to the on-air studio with Dr. Eric Stamberg.
All right, good morning. Welcome to this morning's show. What a difference a week makes. A week ago, I was talking about how dark it was coming in, and now we have, thanks to daylight savings time, some sunlight to come in. But everything, I always say to people and my patients and everyone, everything has a price, right? You know, so the price we pay is now it just gets dark earlier. And I know people kind of like to have debates about whether or not daylight savings time is something that should continue or not. What do you think?
I like the fact that I have a little light when I get up for our show.
There you go.
It's nice to have, not to have to put the lights on when you're walking down the steps to the car.
When you wake up and it's still dark, that's a little weird. But leaving your office for the evening, it's going to be dark.
No matter what, we live in the Northern Hemisphere, and you're going to get a shorter day, one way or the other.
At this time of year. Anyway, okay, so it was nice to come. Some patients ask me about light therapy. It's out there, and it has been studied and found to be effective for people, specifically with something called seasonal affective disorder, which is a nice way of saying you get depressed during the winter blues or doldrums or whatever. But just in general, light therapy can be a good adjunct to treating your emotions and how you feel. It's very common in parts of the country like Alaska where people can have months with minimal sunlight. But I do think about how hard it can be on, like for example, my 87-year-old father, who, just that 1 hour shift in his routine can really be disorienting. He's ready to go to sleep, at the usual time every night, and now that's an hour earlier, so it's a little bit of an adjustment. Anyway, so we have a bunch of topics planned for this morning's show. Our phone number is 331-9255. Rob and I will be here until 9. I want to talk first about something that people may have heard about, and the reason I want to discuss this is it comes up, and people might read articles, they might hear stuff. Their friends might say, you should get this checked or whatever. That happens all the time. And it's these weird things right next to the kidneys. So another word, for kidney is the kidney system is the renal system. So, and when something is right next to it, we put a little AD in front of it. So we're talking about the adrenal system, the adrenals. The adrenal glands are two glands that kind of sit right above the kidneys, and they don't have any function related to the kidneys. Well, I shouldn't say it like that. And it's tough with a conversation like this to not get too technical. Try to keep it layperson oriented. Actually, one of the things that the adrenals does in an indirect way affect the kidneys. The adrenal glands are endocrine glands. The endocrine system is a system that secretes hormones. Well, what are hormones? Hormones are a substance secreted by one part of the body that is then meant to be delivered to another part of the body to have an effect. For example, the pancreas makes insulin, which then goes to the stomach and other parts of the body to regulate your glucose or sugar metabolism. And that's why problems with insulin lead to problems with glucose or sugar metabolism, otherwise known as diabetes. So that's a basic definition of an endocrine organ. It secretes a hormone, and the hormone is meant to travel to another part of the body to have some sort of effect. Other examples of endocrine hormones are your thyroid gland, which makes thyroid hormone that then goes all over the body and kind of regulates metabolism. So it lives in your neck. You also have to look at the pituitary gland, which is kind of deep in your skull. Which Dan is doing a little visual over there, deep in your skull, which regulates many things. Actually secretes a total of 6 hormones, I believe. I have to review that. Might be 8. Anyway, a lot going on in the pituitary gland. So we're going to focus on the adrenal glands because, again, it comes up. People say, have you ever had your adrenals checked? Or you might hear a commercial about an adrenal substitute. So what do the adrenal glands do? They kind of have 3 main sections. And amazing. The physiology and the biology behind it is really amazing. And nature or God's way, whatever, whoever you want to believe in or whatever you believe in. I kind of believe in a little bit of both, to be honest with you. The natural course, but at the same time, the design is so amazing, so intricate that you just wonder, if there's some system throughout the force that is kind of bringing it to us. So basically, these things that the adrenal glands do, it's almost like the body said, we need a place. You know, it's like a business. You know, we need space. We need a warehouse. so it's like I go, well, we have this little space, little real estate located right above the kidneys. Let's put it in there. And kind of like bone marrow, by the way. I'm always amazed at how bone marrow, your bone marrow is where the majority of your cells are made. Your blood cells, I should say. You know, and again, it's kind of the same idea. You know, we need a space to make all these blood cells. I got an idea. How about the middle of the bones? There's not, that's empty space anyway. It's almost like the real estate. So the adrenals have 3 layers to it. One is it has a role in what's called stress hormones, commonly referred to as cortisol. The other one, the layer of it, has to do with regulation of your sodium metabolism, commonly called, we'll call that salt metabolism. And that secretes a hormone called aldosterone. And finally, it has a third layer, which has to do with your reproductive system. It does make some sexual hormones regulating that system as well. However, your body kind of has other organs that do that for men, in your genitalia, basically. So we're not really going to focus on that third category as much because abnormalities of it are a little more, they're less common, and boy, they're awfully weird. It's the type of stuff where someone can kind of be have different types of sexual organs, but we're not going to focus on it because it's too complicated. We're going to focus on the first two categories, which is the cortisol and aldosterone, which is salt. We're going to call salt. So what is cortisol? It's a stress hormone. It helps your body through types of stress. And what do we mean by stress? We mean, well, I guess that's kind of an open-ended discussion, but we mean just what it sounds like. But we mean, first and foremost, kind of physical stress. For example, an illness. If you have an illness, your body will try to maintain itself. It will help you fight this illness by secreting some cortisol. Also, the times of an injury, like a car accident. But there is a role for emotional stress, and people kind of get into kind of the science and kind of what we might call alternative components of medicine. We'll talk about the stress, emotional stress, kind of leading to more cortisol, and then that might lead to undesired effects of too much cortisol, one of which is weight gain. So that's sort of why it comes up in the alternative press, that have a lot of talk about stress hormones and foods that increase your cortisol to try to keep them down, keep the inflammation down in your body. But we do need cortisol, and if we don't have it, if we completely don't have any of it, it could be life-threatening. And a very famous example of that is John F. Kennedy. John F. Kennedy, sometime in the early 50s, had a common illness. He had appendicitis. And when he went to have this operated on, now this is the 1950s, and this is Boston. I mean, we do have a medical system that's functional at the time and knows how to treat appendicitis. He actually develops life-threatening complications during this illness, during the surgery, of low blood pressure that has to be treated. It turns out that he had a problem where his adrenal glands had been eliminated by an autoimmune process. When that happens, it's called Addison's disease. Now, a lot of times people just don't have enough adrenals, so sometimes we call it Addisonism, basically not having enough adrenal gland function. But John F. Kennedy basically almost succumbed to what at the time was a fairly routine illness. It was the type of story that really was not advertised or talked about because he was an ambitious politician, and the idea that you might have a physical ailment would count against you. One of the side effects of this condition, Addison's, again, without getting too complicated, but the pituitary tries to turn on the adrenal glands, which are no longer working, and it will secrete something called ACTH. ACTH has a component of it that leads to bronzing of the skin. So when people kind of look at that hue that John F. Kennedy had of his skin, it was a little bronzy. Would you agree with that, Dan? Okay.
I never noticed that so much. He just had such great hair.
Yeah, he did have great Kennedy hair. Actually, every now and then I do refer to, when I talk to someone about it as Kennedy hair. Yes, he had great hair. Anyway, so that's a famous example of what can go wrong with the adrenal glands. So the reason I wanted to bring this up is two reasons. One is which it comes up in the lay discussions, and people will frequently ask me to have their adrenals checked because they read somewhere or this or whatever. And the other reason is I had a case, and I'll tell you a little bit about the case. The case is a woman in her early 50s who really said she's feeling well, except she's losing weight. She's lost about 20 pounds, 25 pounds. Again, I talk about this on the show. You always start with a history and physical. You always start with interviewing the patient and then doing a physical exam to see if there's any clues. So I asked her many, many times, okay, you've lost some weight. Do you otherwise feel well? Are there any problems? Are you having any shortness of breath? She's not a smoker. Of course, when someone starts to lose weight for reasons that aren't clear, we worry about the C word.
Cancer.
Cancer, yes. Good morning, Ms. Baker.
Good morning.
Okay. We worry about the C word. So I ask questions. Are you having any shortness of breath? Are you coughing up blood? Of course, lung cancer is in the possibility, particularly if you're a smoker. If you're a woman, are you up to date with your women's health? Have you had a recent mammogram? In this case, the woman was completely up to date with her preventative gynecologic health. Are you up to date with Pap smears? Pap smears are kind of complicated. The regimen now. By the way, I was just reading about it this morning about the idea of the Pap smear being the first public health measure to prevent cancer via screening. It came about in 1942, and it was, at the time, cervical cancer was the most common cancer in women. So, 70 years later, phenomenally successful at taking that and making that relatively uncommon. And now we have a whole new era of HPV vaccine, which really might make cervical cancer a complete thing of the past.
Amazing.
Okay. So I was talking about this patient and making sure first, doing a history. Again, I couldn't elicit any symptoms from her other than weight loss. She's over 50, and even if she wasn't over 50, I wanted to make sure she was up to date with colon cancer screening, and she was. And I did a full exam, and other than the fact that the chart showed that she had lost about 25 pounds, everything was normal in the exam. She looked fine. There were no abnormally large lymph nodes, things like lymphoma and leukemia, and just cancer can manifest as large lymph nodes throughout the body. Her lungs were clear, her abdomen was benign. We use that term benign, no masses. Skin exam was unremarkable. That would be another consideration. So we start with a basic workup, and I say that a lot, right? Basic workup. Basic labs. A CBC will be ordered, tell you a lot of things. But if it's normal, it also tells you a lot of things. For example, if someone has an anemia, you have to ask yourself why. And make sure that some sort of blood loss is not a cause of that, particularly colon cancer. Just a routine metabolic profile, liver, kidney, sugar, potassium. And they were all normal. First time around, you do a thyroid test. Remember, an abnormality of the thyroid in either direction might affect your weight. Right? Typically, if someone has an underactive thyroid, they'll gain weight. And if someone has an overactive thyroid, they'll lose weight. Thyroid function was normal. I like to do something called a SED rate and C-reactive protein. I think I talk about that a lot. These are very non-specific tests, but your doctor may order them. If they're normal, they do a good job of ruling out pretty scary things, like cancer and infection. If they're not normal, it kind of tells you something is wrong. It doesn't really tell you what's wrong. Autoimmune diseases also can have an elevated SED rate, like lupus and rheumatoid arthritis. And then SED rate is similar to a C-reactive protein. Again, all normal. And after reviewing her tests, decided, and we still couldn't figure out what was wrong with her. I kind of sent her for a second round of tests. And this time I did a fasting cortisol level. Again, without getting too technical, your body makes cortisol from your adrenal glands. That's why we're talking about it. And, it kind of varies with your time of day, whether you eat or not, what type of stress you're under. So you really want to start the workup for an adrenal problem with a fasting level. And a fasting cortisol level for her was 0. So now where you say, oh, we're onto something here. By the way, I think I also did a chest x-ray. I think I even checked her for tuberculosis. Tuberculosis is thankfully a disease that's not that common, but weight loss would be one of the cardinal symptoms of that.
Cortisol is like sugar?
It is a stress hormone that can result in many things, one of which is increase your sugar. So it kind of works counter, it's so complicated, these hormones that kind of work against each other. But if someone has stress on their body, it can manifest in many ways, one of which is raising the sugar level. That's why a lot of people who do talk about just general wellness talk about kind of a low stress, attempting at a low stress lifestyle. And that includes emotional stress. and physical stress, and a diet that is low low in inflammation potential. We're getting into kind of alternative stuff, and I don't not believe in it. I kind of do believe in it. I always tell people I don't want you to put all your stock in that basket and neglect some other basic stuff. I don't want someone, for example, say, they're doing all this to keep themselves healthy, therefore they don't need to have a mammogram. That troubles me, or therefore they don't need to be checked for diabetes. Anyway,
so what is a normal cortisol level if hers was 0?
I think fasting cortisol, it should be about 20 or greater, and certainly shouldn't be 0. If you got a low level, it doesn't quite make the diagnosis. But in this case, it was 0. She wasn't making any cortisol. There's another test, but again, without getting too complicated, called a Cosentropin Test, where you give a shot of something called ACTH. I already mentioned that. You give it at nighttime, and then you check the cortisol again in the morning. It's a complicated test. So by this point, I had referred the patient to Dr. Batamosi, who's been a guest on our show. She's a endocrinologist who I have the good fortune of sharing an office with in Kingston, and she was able to do this test because it's kind of complicated and has to be ordered correctly and blah blah blah. And then it was indeed abnormal. They were making the diagnosis of adrenal insufficiency. It wasn't. Again, I always, whenever I engage in these conversations, I was always kind of say I don't want to get too technical, because it's tough. It wasn't purely Addison's disease. Her problem was more on the level of her pituitary. But to make a long story short, once the diagnosis is made, the treatment's fairly straightforward because we have replacements for cortisol. Typically, we use hydrocortisone. That's a steroid. You could use other steroids like prednisone or dexamethasone. It's hydrocortisone is the one that's really closest to pure body cortisol. And once that is diagnosed and the person's put on the maintenance, they'll kind of start to feel better. Once we kind of made the diagnosis, I don't know, sometimes the power, of suggestion, the patient did kind of start to admit to some symptoms under duress. No, I'm joking about that. But she did start to say, yeah, she has been feeling pretty tired and not herself. Really vague symptoms that we all kind of experience. And that's
that you wouldn't really pay attention to normally.
No, and that's something that's hard about my job in a way. Well, what's normal versus abnormal? That's why I usually say everyone should at least get a basic workup, because you'll find stuff. But you're right. We could just be fatigued and
right. Who's not a little tired or a little stressed?
Who doesn't have a little brain fog?
Right.
Who feels they're not as sharp as they used to be? Did I raise my hand?
Yeah.
You didn't raise your hand?
No.
Okay. We didn't. Anyway, so she is doing fine. So it's very important when someone with adrenal insufficiency at times of stress, the body needs those adrenal glands to secrete cortisol to react to the stress. That's what happened to John F. Kennedy. He was fine until he was acutely and seriously ill with appendicitis, and he didn't have the ability to respond to this stress. So people with adrenal insufficiency will have to sometimes go in higher doses of hydrocortisone when they're acutely ill.
Can you ever feel your adrenal glands?
No.
No. Okay.
They are deep in there.
Okay.
They are. The kidneys
so,
are deep in there. A lot of times people say, my back hurts. I think it's my kidneys. And you really just a basic exam. If I kind of press a little bit and they go, ow, 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 that's not your kidneys. Your kidneys are really, you got your skin, you got some, blubber there, you got your muscles, you got your bones, you got connective tissue, you got a lot. The body went to great lengths to protect those kidneys.
To protect them, yeah.
Anyway, we talked about it not that long ago, how at the same time they're very painful. If there's a problem with the kidneys themselves, not the adrenals, but the kidneys, like a kidney stone or a kidney infection, it will be very painful. So the adrenals are tucked in there.
So just because your levels are low, that doesn't point to like adrenal cancer or anything. This is just...
That's a good point. That's something I wanted to mention. Is we live in an era where we do a lot of medical testing. A lot of people, for example, have CAT scans of their abdomen for different reasons. They're having abdominal pain, for example. And the radiologist is trained, thankfully so, to not just look at the reason we're doing the CAT scan, but to also look at the entire
everything
area.
else.
So it's common for people to say you have something on your adrenals. These are called adenomas. Almost always these are benign. These can rarely be cancer. The number is quite low, probably about 1% or less than 1%. And there are very strict criteria about which ones need further attention or which do not. Sometimes they just need some form of annual imaging, and if they're really not changing in any way, you can really ignore them. But it's hard. First of all, the term adenoma, that's kind of scary sounding, isn't it?
Yeah.
But it really doesn't mean anything is malignant. And these adrenal adenomas can cause a lot of consternation amongst patients and can lead to, more testing. So, this is what we deal with. Testing can beget more testing. It says in the Bible, Old Testament.
Don't think
Old Testament.
Old Testament, yeah, Testament. All right, enough of the Bible joke.
So the daughter of my good friend Natalie, who's battling with a malignancy right now.
Right.
Everyone listening, you could pray for little Natalie. She's a fighter, and that's a neuroblastoma.
Yeah. I think it's different because the neuro implies that comes from the neuro system in some way. So you have these ganglia, these nerve cells throughout your whole body, and including the adrenals. Again, the brain has a way to communicate with the adrenals as well. Why does emotional stress therefore stimulate maybe a surge in your cortisol level? So the neuroblastoma kind of refers to the tumor that's arising from there. When you first told me about this story, you and I were talking about other types of pediatric tumors in the in that area, the kidney area and the adrenal area, that we were kind of hoping were a little more easier to treat. It sounds like this young girl is getting the appropriate treatment and so forth, doing well. So
yeah,
we wish her well and her family. Yeah, and I also had a patient in the hospital over the weekend who doesn't have her adrenal glands. So this story is interesting too. Well, first of all, she had kidney cancer. Remember, you have one on each side. So she had kidney cancer, and you got to when someone has kidney cancer, generally you got to remove the entire kidney. There are times where they remove just partial kidney, but if you can't take the kidney out and leave the adrenals, they're right next to each other, and it's just I don't think it's surgically possible. So on one side, she took the other one out. And then she had some imaging done that showed the adrenals to have a growth. And again, using criteria, it was this growth was felt to be concerning enough to warrant removal. Now, she did end up not having adrenal cancer. But again, everything was appropriate in following guidelines. I'm glad she didn't have adrenal cancer, but she's now left without adrenal glands. So she has to be treated with lifetime cortisol, hydrocortisone. So that's an example of someone who has the condition for surgical reasons. So cortisol, just to remember. So yeah, again, it shows up. In the lay press, you'll hear ads about products that boost your natural cortisol. You hear about products that suppress your natural cortisol. I'm all in favor of a healthy diet. I'm always a little cynical and skeptical about that. We have 1 minute to our first break. You have a question? You look like you have a question.
And the cortisol, having it be proper around 20, is that what you said?
Yeah, I'd have to go. I think maybe it's 16 or less, but yes.
It's just going to keep you feeling well? I mean, what's its purpose?
Your purpose is to maintain, we use a word called homeostasis, to maintain stasis in your body. And so a certain level of cortisol is needed for normal function. At times of stress, the body will release more cortisol that will help you through that time of stress. It comes with a price, for example. It's very common, for example, someone who's seriously ill to have their sugar go up and be diabetic for the first time in their lives. And once the stressful situation is fixed, they'll go back to being non-diabetic. Anyway, we're going to go to our first break.
Thank you, Dr. Eric Stamberg, Robin Baker. And you're here at this 7:30 moment, and that was our first segment of Medical Mondays with Dr. Eric Stamberg and Robin Baker. You're listening to KCR, Kingston Community Radio, on AM 920 and 92.5 FM. My name is Dan Gatis, and it is 7:30 a.m., Monday, November 8th. 30 degrees here in Uptown Kingston. We'll be right back after these messages.
As warm days slip away and the weather gets cooler, most of us will begin restarting our home heating systems. And that's when the threat of carbon monoxide poisoning is most critical. This potentially lethal hazard can occur with any furnace or boiler, so be sure to have yours professionally serviced regularly. Make sure chimneys and exhaust vents are clear, and use carbon monoxide detectors throughout your home. Central Hudson reminds you, your safety matters. Central Hudson's mobile app has a new look. It's the place to view and pay bills with ease. Check your electric and gas usage to better manage your energy consumption to save money. And report an outage, anytime, anywhere. Use the app to easily submit your meter reading to avoid estimated bills. Download it today from the App Store or Google Play. It's free and easy to use.
This is Nina Poshupak. Once again, the WGHQ Happy Christmas Fund is asking you to help the needy this holiday season. For the last 50 years, the WGHQ Happy Christmas Fund has helped less fortunate families have a happier holiday. Look for our collection boxes at the local branches of the Ulster Federal Credit Union, Roundout Savings Bank, the Mid-Hudson Valley Federal Credit Union, Ulster Savings Bank, and at Cantine Field and Saugerties. Thank you and have a happy Christmas.
And we're back, and thank you for being with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM. And let's get back to the on-air studio. This upcoming portion of Kingston Community Radio is being brought to you by Central Hudson. And it's 30 degrees here in Uptown Kingston. It's on a Monday, November 8th. And at the 8 o'clock hour, we will review what the weather is. And our call-in number is 331-9255. Lines are open, 331-9255. And let's get back to the on-air studio with Dr. Eric Stamberg and Robin Baker.
All right. Good morning. Good morning, Ms. Baker.
Good morning.
What do you think? We were talking about how nice it is to drive in this week with some sunlight compared to last week.
Yeah, but it's like dark at like 3:30 in the afternoon.
Everything has a price.
I know.
Remember last week, though, I was commenting on how dark I couldn't even, when I left my house last week, I couldn't even see the hand in front of my face.
I know. It's a kind of a sad time of year.
Well, we did talk briefly about light therapy. And you can get these lamps, on any website. I'm not going to mention one over the other. They do study this. They take, two groups of people, and they have one group of them do some light therapy and the other not do it, and they compare symptoms, and there is improvement in the light therapy group.
It's a happy light.
Right, because we were referring to it as the sad lamp, which is a weird term Right. So we decided to call it the happy light.
Right.
Anyway.
Change perspective there.
Right. It's interesting, to finish this kind of little section on cortisol. There are emotional effects of cortisol, both low and high, that are similar. We were talking about deficiency of cortisol with the cases I was mentioning, but they can lead to depression. Remember, it lowers your whole energy level. This other condition where there's too much cortisol, sometimes that's called Cushing's, it can also lead to kind of an emotional condition of feeling depressed. So some people make too much cortisol. And that, again, is called Cushing's syndrome. Sometimes we use the term Cushingoid. There is something called Cushing's disease, which is actually on the level of the pituitary, but then the end result is making too much cortisol. So this comes up a lot too, and this also will come up in the lay press. Maybe you can't lose weight because your body makes too much cortisol. You should have your cortisol checked. It's not part of a routine workup, at least as far as I'm concerned. I mean, if I'm going to run some labs and it kind of comes up, it's it's okay to do a fasting cortisol level. You don't need to proceed with testing about that. But the symptoms of too much cortisol are kind of the opposite of too little cortisol. Where in Addison's or too little cortisol, you kind of lose weight and waste away. In Cushing, you'll kind of bloat and kind of gain weight. You kind of there's a classic appearance of someone who has too much cortisol. They get kind of a chipmunk look to their face. What do you call it? Puffy cheeks. And actually, it's much more common because we do use things like prednisone a lot. People who have to go on long-term prednisone for many reasons, whether it's bad lungs or whether it's an autoimmune condition like rheumatoid arthritis or a neurologic condition or steroids do have a role in cancer treatment as well. So people can kind of get what we call Cushingoid as a result of too much cortisol. They get this classic look. And then, yes, they'll gain weight, and it will make your sugar go up, and it might ironically make your energy level go down, and you'll feel kind of bloated and kind of slowed down, and it might affect your cognition. So the effects of these hormones are rather ubiquitous.
Is the adrenal gland responsible for anything else?
Yes, they are, Robin. Thank you for asking. We started the conversation by talking about the 3 levels of the adrenal. So that's that's actually the middle level, but we don't have to get into that. It has a role in your sodium or salt metabolism. So it secretes a hormone called aldosterone that, again, regulates your salt. Remember, we gave the definition of a hormone as an endocrine gland as a gland that secretes a substance called a hormone that is then meant to travel to another part of the body to have a desired effect. So the aldosterone, ironically, travels to the kidneys. Even though it's right next to the kidneys, it has to get into the bloodstream and then travel around to the kidneys, and has a role in sodium retention and therefore sodium maintenance. Again, it's very complicated. It's hard to have this conversation kind of keep it simple, so to speak. It's one of the challenges. But if you have too much aldosterone, it will lead to high blood pressure. And this is something called Conn's syndrome, CONN''S. It was described as a rather rare cause of hypertension. It's probably more common than we think. And I was talking to one of the residents about this yesterday over at the hospital. When do we look for something like that? Whenever someone is diagnosed with hypertension, we always want to briefly or in a basic way consider other causes of high blood pressure. And that's why a basic workup should always be done. Again, metabolic profile, maybe we check the thyroid level, because remember, thyroid disease in either direction can also affect the blood pressure. But if someone has too much aldosterone, that might be causing too much water retention and therefore high blood pressure, their basic electrolytes should be abnormal. Their sodium should be elevated, and there's kind of this complicated trade-off between sodium and potassium that's done on the level of the kidneys. So if the sodium is elevated, potassium will be low. So generally, just basic blood work will really reveal evidence of that. But it is something to be considered in someone who has resistant hypertension. And resistant hypertension is defined as someone who needs 3 or more medications to treat their high blood pressure. And that's, to be honest with you, that's kind of a lot of people. So it's a little bit of what we call zebra. Remember that phrase?
Mm-hmm.
That's a common phrase we use in medicine, which if you hear hoofbeats, you think horses, not zebras. So in other words, we consider the common things first. Thyroid disease, for example, is much, 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 much more common than Conn's syndrome. But if people are lacking their adrenal glands, they'll also have deficiency of aldosterone. And that will lead to salt wasting. Well, what will that lead to? That will lead to the patient with that problem is at severe risk of being dehydrated, particularly in times of stress. So that's why when someone has one of these crises due to adrenal insufficiency, in addition to giving some cortisol, it's very important to maintain fluid balance, give a lot of IV fluids. And if someone is deficient in aldosterone, we do have a product that's very easily described called fludrocortisone. The brand is 4NF, and they might need to go on that. And if they go on that, they usually fixes that problem. Ironically, someone can still have high blood pressure and be deficient with aldosterone. So even though 4NF will cause fluid retention and therefore might raise, it's kind of the opposite of a diuretic in a way. Remember we give diuretics to lower blood pressure. So if someone has 4NF, it might raise the blood pressure. But sometimes we have a patient who needs the 4NF because they are deficient in aldosterone, but they still have high blood pressure, so they need to maybe take other medications to treat that. We have some medications that counteract aldosterone, something very commonly prescribed called spironolactone. I don't know, maybe people have heard of it. So if someone has Conn's syndrome, that's the treatment. It's spironolactone. It basically counteracts the aldosterone, brings your pressure down, corrects the electrolyte abnormalities. So it's kind of similar to what I said about Addison's. Once the problem is identified, it's actually fairly easily treated. And the third layer of the adrenals have to do with sexual function. If someone is born with some enzyme deficiencies, they can have too much or too little of their sexual hormones. And interesting things can occur, like someone can have elements of both genders, biologic. We're not getting into the topic of
identification, right?
Biologic genders, which is called hermaphrodite. They're basically a hermaphroditism. But that's complicated stuff. But that is one of the reasons why just part of geriatric care, part of newborn care includes an examination of the genitalia, because that would manifest as abnormalities in that area. But we do have other organs that help us, that secrete sexual hormones for us. Women have ovaries, men have testicles. So if someone has Addison's, they don't necessarily need supplementation in that part of the adrenal function. It's almost like a backup plan. We also see that with the body too, kind of like sometimes a backup. It's interesting.
So that just keeps your estrogen or your testosterone levels where they should be?
Yeah, but it's almost like it's almost like a backup system, but it's, I don't know, because testosterone is an interesting topic, and it does come up a lot. A lot of male patients ask me to check their testosterone levels. And even women need testosterone. It actually has a very complicated balance between estrogen and testosterone that can occur in many parts of the body. It actually occurs in fat tissue, what's called adipose. It's one of the reasons why when people get heavy, women have problems with their weight. They also might have some male factors kind of take over, some receding hairline or some hair growth in parts of their body that they don't want it. It's interesting. And in the category of women's sexual dysfunction, sometimes testosterone is prescribed because it has a role with libido. But men ask to have the testosterone checked a lot, and I'll check it. I think it doesn't really cause erectile dysfunction. It causes kind of the male menopause. You're a little bit older, you're in your 50s, you're a little more fatigued, maybe your muscle mass is going down. That's known as aging, by the way. So male menopause is kind of the aging process. It can affect your libido, but doesn't really affect your sexual function. Matter of fact, testosterone replacement can almost worsen sexual function because your body still is making some of its normal testosterone. And the real thing is always better than the artificial thing. So if you give a man testosterone, it might cut off what the man is still making on his own. So it's interesting. But I sometimes, because testosterone is a hormone that can be linked to some adverse problems like clots in your heart, clots in your brain, clots in your leg. I sometimes think that the male menopause is, again, a biological way of cutting back on the testosterone, because as we get older, those things become all higher risk. So I don't take the decision to put a man on testosterone lightly. I think that I've seen some complications of it. Some men get clots, and And I really think it has to be a good reason. The symptoms have to be clearly defined, and the level really has to be significantly low for me to recommend that. So normal is usually 250 or greater. If it comes in at 240, I don't want to put that person on therapy. But if it comes like a 100 or 50, I usually refer the patient for a second opinion as well. And who should see that patient? An endocrinologist could help because it is a hormone, and also a urologist because it's part of the male reproductive system, and they specialize in that. So that's a little bit on testosterone.
So when you go to the gym and you see that there's people who are bulking up, like their muscles are abnormally bigger than
right. Yes.
Anyone who's like picking up heavy things and putting them down. Are those, they can supplement, right? Those are when...
Well, yeah, are you talking about what we call anabolic steroids? Yeah, again, it's very complicated, but when we're talking about things like prednisone and hydrocortisone and dexamethasone, those are not kind of your weightlifter steroids. Those are different steroids. So those could be more closely related to testosterone. And that's why the part of the problem of those meds is linked to what happens when you have too much testosterone. For example, it can make your skin oily and you can get acne. Well, what's happening to a teenager, including girls, because they have a surge of hormones as well. But your teenage boy has got testosterone oozing out of every part of his body. So, acne, oily skin. It's interesting. The hormones that we were already talking about, prednisone, hydrocortisone, dexamethasone, they actually, in higher dose, will lead to muscle wasting. That's one of the symptoms of Cushing's disease. So it shows you how complicated it is. But too much hormones can, the weightlifter hormones can lead to fertility problems because it shuts off your body's own testosterone, shuts off your body's own sperm-making ability. It can lead to some cognitive problems, some depression, some anxiety, some anger. It can affect your blood pressure, raise your blood pressure. It can affect your heart function, cause kind of cardio. Remember, your heart's a muscle too, so you're trying to stimulate your muscles to grow more. You might, in a negative way, be affecting your heart muscle. So no, we really don't like that. And I have a young man in my family who's very into this stuff, and we weightlifting and taking care of himself, and he tells me that it's commonly done. It's commonly done amongst young athletes, including high school level athletes. Again, everything you can get with just a few clicks away. So it makes me nervous. So we don't like that.
Right. You don't normally make that, though. It's not something that is normally made that...
You kind of normally make it. That's why, if you're working out, your muscles will get bigger. It's just that you're kind of supplementing to really get ahead of the curve. And that's part of the problem in a way. If you have someone who's a young competitive athlete, a good basketball, a good football player who wants to play in college, sometimes you get in this mentality where if everyone's doing it. So if you're the only one in the room who's not doing it,
how do you keep up?
And that's what happened to baseball in the 90s, where we're still kind of having this argument about whether or not Barry Bonds and Roger Clemens and Mark McGwire should be acknowledged with the Baseball Hall of Fame, even though they used anabolic steroids. So, one of the argument is, yes, they used it, but in a way everyone was. So if they did better, they were still better than the bunch. But then you have a guy like Frank Thomas, who, by the way, is on TV now, hawking a testosterone supplement, and Jim Thome, these were our power hitters of their generation who did not use steroids. So it's an interesting discussion, but a little bit off topic. What do you think? You think baseball should just say whatever and let them in?
Baseball-wise? Yeah, I don't know about baseball.
No, but this is like, you're talking about the Baseball Hall of Fame, which is enshrinement. This is the ultimate goal of any athlete, to be enshrined in the Hall of Fame. But there's a whole generation of players who are, their numbers, their stats are marred by steroid use.
I'd have to look at it differently. They took away the, who's that guy, the
Pete Rose?
No, the guy who's a bike rider.
Neil Armstrong, right? Not Neil
No.
Armstrong. Jack Armstrong.
No.
Lance Armstrong.
So didn't they take away his title? I mean,
He did. Well, he was caught doing that during competition, because they'll test, a lot of sports will test like right prior to that. For example, some people like marathon runners and bikers who it's an endurance sport will use something like testosterone a couple of days before because it will increase your blood cells and therefore increase your oxygen capacity and therefore increase your endurance. And that's where that comes from.
so I don't know. I guess if he had his title taken away, that
Who's Lance Armstrong?
right.
No, but that is Lance Armstrong.
Yeah.
It's Jack Armstrong.
I don't know. You're just making stuff up now.
You know who Neil Armstrong is?
No, Eric. I don't know who Neil Armstrong is.
I won't quiz you. We're on air.
You're so dumb.
Moon,
What?
1969.
That's right. That's right. I mean, amazing weekend in history. It was the same weekend because same weekend as the Woodstock Festival, and it was also the same weekend as the Chappaquiddick story. And if you see the movie that came out a couple of years ago, they kind of took advantage of that to keep it out of the press, so to speak, because there was more going on. Anyway, why are we talking about that?
Because you asked me about Barry Bonds.
Yes. All right.
So that's anabolic anabolic steroids as opposed to
oh gosh, metabolic is sometimes is used. There's different types of steroids, and that's what's important. So when we use prednisone so often, we use it for poison ivy, for example, because it suppresses the allergic reaction that leads to poison ivy. See, there's an example. Even though it boosts parts of your system, it suppresses other parts of your system. It's complicated. So every now and then when I say, I think you need to, I'm going to recommend you go on some steroid, the patient goes, it gives you this kind of reaction. Like you just suggested they take a cyanide tablet or something, and you have to kind of explain that this is.
Well, it is amazing how different people react to the same kind of medication. Because some people feel better on the medication. Sometimes if you take steroids, it like speeds you up and you get like you can't sleep and you can't.
Right. I tell you, it's funny. The stories can be so funny. Someone will say, "Yeah, I love that prednisone. I cleaned my house." Sometimes the spouse is like, "Yeah, give it to her again, doc." But other times it kind of like it's a too much coffee type of speeding up, and it's not good.
No, it doesn't feel good.
And it can be tricky in people with psychiatric problems like bipolar disorder. Prednisone can flip them completely into a manic episode. See how complicated this is? It's a hormone that. It kind of has a lot of physical effects, but clearly has an emotional and psychiatric effect as well. So it's complicated.
So we were just talking about the happy light and how this time of year with the it being dark so long and like people feeling a little bit like depressed or under the weather. Is that something that you should talk to your doctor about? I mean, do you bring it up? I mean, isn't everybody a little down sometimes? I mean, how do you know the difference between whether you should talk to your doctor about that or not?
That's a very good question. First of all, we're supposed to be screening for depression, okay? And it's when I did bring a book a journal that talks a lot about screening, including screening for depression. The evidence to justify it and support it is quite good. That being said, what's our biggest enemy, in the office? Time, right? I mean, this is, and Rob and I are going to make T-shirts for Medical Monday. Dan, what do you think of this? Medical Monday, it's a big topic.
It's a big topic.
Yes.
Yes.
It's complicated.
It's complicated. That'll be our second round of tea. We'll do that in the back of the shirt. What are we talking about?
We were talking about when do you kind of discuss being sad with your doctor and like what's usual, what's unusual? I mean, I guess if you're like in it, right? I mean, if you're very, very sad or...
We have some screening questions we ask, but I try to get an assessment of how much it's affecting their life and trying to differentiate with just a normal mood fluctuation. You know, we all have ups and downs. We all have things that don't go well, illnesses, financial difficulties, you know, problems at work, whatever, you know, in our relationships, whatever, versus something that is more of a pattern or something that really needs treatment. For example, you know, depression, for example, can be caused by something. Someone can get, you know, diagnosed with cancer, or a loved one can get diagnosed with cancer. That can lead to depression. Someone can get, you know, divorced. Someone can lose their job. You know, so how do we separate what's called the adjustment of the stressful event from the pattern? And actually, it's usually in the psychiatric handbook, so it's done by time. You know, for generally, if something 6 weeks out is really still causing significant problem, and 3 months out, you know, then it's really no longer an adjustment disorders. I believe, I wish I had a psychiatrist here, are really defined by lasting 3 months or less. So if something is really sustained over 3 months, it's more of a depression, and that might merit its own treatment. There are other ways to treat depression. We're talking about that. You know, we talk about light therapy. We're talking about counseling. We're talking about
exercise,
other types of cognitive type patterns. CBT, you know what that stands for?
Mm-mm.
Cognitive behavioral therapy. You know, it's based on a basic tenet of neuroscience that negative occurrences are much stronger on cementing synapses than positive. You know, so it's a challenge to kind of rewire the brain if someone is kind of having negative feelings. And again, it can, to try to get that more positive. That's called cognitive behavioral therapy. It's been studied. It is effective. It takes time. It takes commitment and energy. And then we get in the role of medications as well, are commonly prescribed. I do have a couple basic rules for someone, basic etiquette with your provider. You know, this, again, we're joking about it, but it is a big topic. So if you do want it addressed at your appointment, you should really bring it up early. You know, it's very common for me to kind of go through everything, you know, and then kind of be wrapping up the visit, you know, because remember, our biggest enemy is time, and have someone kind of bring it up at the end, you know. It's not a new, by the way. It's commonly referred to as doorknobbers, you know.
Well, sometimes it's hard to talk about.
It's hard to talk about. I agree. And we should be screening for it too. But part of the problem with screening is they always want a screening tool, and then you get a whole very cookbook, and you look at the, you know, checked off enough boxes. You know, someone will frequently screen positive, and then I'll ask a few questions, and they're like, no, you know, I'm just a little down because of COVID or whatever. And we kind of say, okay, you know, you're a little down. You know, we're not going to treat depression because I don't think you have it, screening or not. You know, it's at the end of the day, it's a judgment. But although I usually take advantage of the opportunity to encourage other activities that might help someone feel better.
Right, like exercise,
hobbies. You know, gosh, what's old is old. You know, remember how everyone had a hobby. We had a neighborhood hobby store. You know how important that was to have a hobby, and I don't know. People still have hobbies. I think.
Yeah, they really do.
I think the hobby, you know, mostly is, you know, competing with this.
It competes
with the phone. And, maybe 1 minute to our next break. But we had a great bottle store right here in Uptown Kingston. I used to love that store. You know, but they're not there anymore.
Right on Front Street.
Yeah.
Mm-hmm. Hobby stores aren't easy to find anymore. Little pieces of balsa wood right, and all those little things that you use to make models and stuff.
Although some hobbies, you remember the wood burning kit? I'm like, well, this is a good idea.
It was fun. I had one. I had one. I was very well supervised, thank heavens.
Oh gosh!
But I probably did burn myself at least once.
Well, what about soldering? Remember soldering?
Well, that's my stock in trade. I'm in electronics, and
I
do a lot of audio work. So
cool.
Soldering is a stock in trade, so not a hobby at all.
There you go.
It's a necessity.
That's a fun topic. The listening audience can talk about like all the dangerous things that, you know. I mean, we didn't have seatbelts, so we were really running the risk. Well, we're talking about like picnics and things.
Yeah.
And we have jarts.
Oh, charts. Yikes. All right, we're going to go to our second break, and we'll be back after that. Remember, 331-9255.
Thank you, Dr. Eric Stamberg and Robin Baker. Many thanks. And KCR is Kingston Community Radio, and it is Monday, November 8th, and 34 degrees now here in Uptown Kingston. This last portion of Kingston Community Radio has been brought to you by Central Hudson. And we'll be right back after these messages.
As warm days slip away and the weather gets cooler, most of us will begin restarting our home heating systems. And that's when the threat of carbon monoxide poisoning is most critical. This potentially lethal hazard can occur with any furnace or boiler, so be sure to have yours professionally serviced regularly. Make sure chimneys and exhaust vents are clear, and use carbon monoxide detectors throughout your home. Central Hudson reminds you, your safety matters. Central Hudson's mobile app has a new look. It's the place to view and pay bills with ease. Check your electric and gas usage to better manage your energy consumption to save money. And report an outage, anytime, anywhere. Use the app to easily submit your meter reading to avoid estimated bills. Download it today from the App Store or Google Play. It's free and easy to use.
This is Nina Poshupak. Once again, the WGHQ Happy Christmas Fund is asking you to help the needy this holiday season. For the last 50 years, the WGHQ Happy Christmas Fund has helped less fortunate families have a happier holiday. Look for our collection boxes at the local branches of the Ulster Federal Credit Union, Roundout Savings Bank, the Mid-Hudson Valley Federal Credit Union, Ulster Savings Bank, and at Cantine Field in Saugerties. Thank you and have a happy Christmas.
And we're back, and thank you for being with us here at KCR, Kingston Community Radio, AM 920 and 92.5 FM for a wonderful Medical Monday. This portion of KCR is underwritten by Sawyer Motors. Bob Circasano and the whole Sawyer Motors team on 166 Ulster Avenue in Saugerties, New York. 12477 845-247-5027. 845-247-5027. This upcoming portion of Kingston Community Radio is also brought to you by Herzog's. Stop by Herzog's Home and Paint Center in the Kingston Plaza for all of your home building and maintenance and painting needs. Discover the difference of buying local, sales ongoing on their website at herzogs.com. Great sunshine today with a high of 61. Clear skies tonight with a low of 35. And Tuesday, except for a few afternoon clouds, the same. Mainly sunny with a high of 61. And Tuesday night, cloudy with a low of 43 degrees. And Wednesday, a few passing clouds, but otherwise very sunny. A high of 61 on Wednesday and a few clouds Wednesday night with a low of 31 degrees. Let's get back to the on-air studio with Eric Stamberg, Dr. Eric Stamberg, and Robin Baker. See, they've got some birthdays out, I think.
I am sorry to break the news to you, but we do not have birthdays.
Wow.
It is a lonely, empty file here. We have some announcements. Here you go, Robin.
Wreaths across America?
Wreaths.
Wreaths.
Is it wreaths or wreaths?
Wreaths.
Okay, never mind. Let's move on.
How do you say TH?
Or the.
Wreaths across America. The Saugerties VFW Post 5034, sponsoring a bus trip to Saratoga National Cemetery to remember the fallen, honor those who serve, and teach the children the value of freedom by placing wreaths at the grave sites. This is Saturday, December 18th, 2021. It's $15 a person. They're going to leave from the Greco Senior Center at 10 o'clock and return around 5. They'll have a cash lunch stop. To purchase more wreaths, the cost is $15 each. If you have any questions, you can contact Bob Howe. His number is 845-246-8510. It sounds like a wonderful
it really does.
Trip, and so you can go ahead and sign up. Saugerties VFW Post 5034. Bob Howe is your contact person, 845-246-8510.
Right. How about this? The Snowflake Festival.
That's Uptown Kingston, right?
Yes, Friday, December 3rd, 6 to 8 p.m., Uptown Kingston, presented by the Cuba Network. You know what Cuba stands for? K-U-B-A. The Kingston Uptown Business Association.
Nice.
All right, so it's 6 to 8 on Friday, December 3rd, Uptown Kingston. There is a raffle that will close on November 15th. I guess you got to buy tickets before then. For kids under 12, winners must pick up bike at festival. I'm not quite understanding this, but it's helmets and locks presented by Bike Friendly Kingston as well. Big thanks to the sponsors: Catskill Hudson Bank, Berardi Real Estate, and BHHS Hudson Valley Properties. Okay, so let me just sum this up. It's a Snowflake Festival, Friday, December 3rd, from 6 to 8 p.m. And here.
Yeah, I think Dan was just talking about the Happy Christmas Fund, right?
Yes.
They're hosting the 56 WGHQ Happy Christmas Fund Radiothon. That's going to be at Boyce's Dairy Milk House, 62 O'Neill Street, from 7 to 5 on, they had it, Thursday, November 4th.
There you go.
Yeah, so they already did that.
Oh, that's old? But I think they're still accepting...
You can make checks payable to the WGHQ Happy Christmas Fund.
Until what? Remember the date Lauren said? Dan's eating. What the? Never mind.
You wanted to
all the way
Venmo,
till Christmas Eve.
they'll accept right up to Christmas Eve. You can Venmo through Lawrence Maxwell at Kingston Community Radio. If you're up to date with your Venmoing skills. You can check out the website at www.mykcr.org and our Facebook page, Kingston Community Radio, if you want some more details.
Okay.
So we're talking about, we kind of got off subject. We never do that, but off
right.
subject. When do you think you should speak to your doctor about maybe feeling down?
Well, maybe you can answer that. When do you think someone should bring it up to the physician or healthcare provider?
I guess if you find that it's interfering with your regular, everyday activities, right?
Right.
On your life a little bit.
Yeah. And so a lot of times it's the family member that will bring it up. You're right. Some people don't want to discuss it, and our biggest enemy in the office is time, and this conversation takes time. So, it can be difficult, but you should bring it up. I just recommend that you bring it up early in the appointment, not at the very end of the appointment, because I want to avoid, just the magic pill approach to it. Just like throw. Okay, here, take some Prozac, you'll be fine. Remember that Prozac came out in the, I think, 86. So it's been up 35 years now. And, it changed everything, right? But you remember Prozac Nation? That was a book that came out about 5 or 10 years after Prozac. But the idea that all we needed to just take was this pill and we'd all be fine. It's,
really not how that works.
Always more complicated.
Yeah.
All right. Yes.
So what are some interesting cases that you came across this weekend?
We talked about the one with the adrenal insufficiency, and I have some other topics to bring up, but I guess the price of like finding things on testing that kind of then opened the door, and I use the phrase hallway, send you down the wrong hallway, So one patient has been having a hard time with symptoms to her right ear over the past couple of weeks. Discomfort, fullness, ringing, and then started to experience vertigo, and it got worse. So she had already seen an ear, nose, and throat doctor who diagnosed her with something called labyrinthitis. The inner ear is sometimes referred to as the labyrinth. It looks like kind of like a coil, kind of like a maze. And you can get labyrinthitis, which is actually not a fun condition. It is. It will then lead to dysfunction of the inner ear. It lead to vertigo. It could also, because the inner ear has two main purposes. It has a role in balance. So if it malfunctions, you'll get vertigo, classic vertigo, and it also has a role in hearing. So if it malfunctions, you'll maybe your hearing will be diminished. At the same time, you might get ringing. You might get a machinery noise. Ironically, you might get more sensitivity to loud sounds, just kind of a distorted feeling. Anyway, so she came into the emergency room and had a CAT scan, which was read as a possible stroke, and then kind of like the wrong part of the brain. But we have to take this seriously. So she wasn't feeling well anyway, and she needed some admission to kind of help her stabilize and feel better. But the big long story short, the an MRI was done, which did not show the presence of a stroke. We were able to discharge her. So the teaching point there is that testing can send you down the wrong hallway. That's why it's incumbent on a guy like me to make sure that the tests are done for good reasons. But I want to give you a caveat. I think that in this case the test was done for a good reason. But I deal with this in the office. Doc, I want to be tested for everything. Can't you just order a full body MRI? And by the way, I think there are companies that do that. We call it a car wash. You can get an MRI car wash. Got to pay. Who knows how much they charge? And anecdotally, they'll justify their services by saying, we diagnosed one aneurysm, but testing can open the door to more testing that may or may not be worthwhile. I did want to touch on something that we talked on again, because it does touch on that subject, which is lung cancer screening, okay? Because I still think this is something that's relatively new and therefore underutilized. And the USPSTF, the United States Preventative Services Task Force, which I believe is a subset of the CDC, has really expanded the role of this. What's that?
The criteria?
Yeah, the criteria. And
so it's a low-dose CAT scan.
Yep, low-dose CAT scan, LDCT. So, Matt, this has come up for years, too. Doc, I smoke, or I used to smoke. Can you do an annual X-ray on me? And doctors did do that, to varying degrees, but the evidence never really supported it. Generally, if something is seen on your X-ray, it's probably already a little further along than we want to diagnose it anyway. So the way to really appropriately screen someone for lung cancer is a CAT scan. And it's a specific protocol, emphasis on the LD. Remember, CAT scans do involve radiation, so we want to minimize radiation, and this test does it. That's where the low dose comes from. So who should get this? Well, the criteria has been changed. The prior criteria were people between 55 and 75. Well, now it's for people between 50 to 80, which kind of makes sense in a way. We've known, people in their early 50s getting lung cancer.
Yeah.
Although, unfortunately, Robin lost her mother to lung cancer at age 48. The current screening would not include her. I bet you it's going to be lowered at some point to 45 in people who meet criteria.
So when you say lowered, somebody who's 45 can't get this test?
No, not based upon current guidelines, and What
do you mean? They could get the test, but it's not going to be covered?
Yes. Now, someone might have a symptom, that might merit a workup. If they're having a cough, for example, it's not, and then they are a smoker. I mean, one of the problems with this is, are people then going to use this as reason to not quit smoking? Oh, look, I just had my CAT scan. Doctor said it was fine. Hey, well, look at me. I've been smoking for 40 years, and I don't have cancer yet, so I'm going to keep smoking. I mean, we want people to know that it will happen.
I thought that the screenings, those low-dose cancer screenings, were only for people who have quit already.
No. It's actually
okay.
It's for current smokers, or they have quit within 15 years. 15 years is a long time. So if someone quits at age 60, you're supposed to be getting this test annually until you're 75. And so the lower age was lowered from 55 to 50, and the higher age was raised from 75 to 80. Also, the degree of smoking was changed. The prior cutoff was 30 pack years. What's so funny? 30 pack years of smoking has been lowered to 20. So what is a pack year? Well, it means pack per day per year. So if you smoked 1 pack per day for about a year, that's 1 pack year. If you smoked half pack a day, I've had patients who don't meet criteria because they weren't having enough of a smoker. Now, I think people are minimizing that. They don't want, I think it's unusual for someone to smoke half a pack a day. I think generally if they're smokers, they're probably hitting pack a day. But every now and then you got people that are just kind of what they call social smokers that get together with their friends and, have a cup of coffee or have a beer. But I just think most people are smoking probably about a pack a day. Do you agree with that?
I probably, yeah.
Yeah. What do you think, Dan? You think that's probably true?
No, I've known plenty of people who could smoke four cigarettes a day. No, half a pack, 10, something like that. I've known quite a few people that could do that. So it is doable, which makes it hard to measure when it comes when it comes to getting your testing done.
Yeah. So the age range has been expanded by 10 years, and the degree of smoking to justify the testing has been dropped, so more people are eligible for this screening, and it's worked. I've had a couple cases picked up, and these are very fortunate individuals. I just really want people to quit smoking, but it has happened. There was a time where they were also recommending what's called spirometry, kind of like a breathing test to screen smokers. Amazing how things change. And part of the logic was then you could then use that ammunition to try to encourage someone to quit. For example, if I did the lung test and it was abnormal, I could say, look, you're starting to get emphysema. You really better quit smoking now before it gets worse. If it was normal, I could then say, hey, not too late. Your lungs are still normal. Now's a good time to quit. Here we are, 20 years later, and it's just not something that I. It takes time, and it's just not something that I found to be too helpful, to be honest with you. So I don't really do it as much anymore.
But you do order this screening.
Yes, and I think it's underutilized. So people listening, if you have yourself or family members or friends, and this criteria, I'm going to review it again, between ages 50 to 80, current smoker or having quit within the past 15 years, and have a 20-pack year history of smoking. And I think that's a lot of people. I think there's a lot of people who are still under-screened for that. I tell you about the TV commercial I saw? I couldn't believe this commercial. So this is just morning CNN or whatever, and it's from a lawyer, and they give a little vignette of a man who looks like he's about 60, who gives the stories that he's been diagnosed with lung cancer, and then he says, it turns out my doctor was supposed to be recommending this test to me, and he didn't, so immediately kind of opened the door to not just the fact that this should be done, but to litigation if it's not done, and somebody winds up having cancer. So, in a way, those are the sharks circling the water there, but, the end result, though, is that the take-home is that if you meet this criteria, you should be screened, and yes, someone like myself should be reviewing and recommending it. And that's why I always emphasize an annual visit. No matter who you are, no matter how old you are, I think a time to just focus on these other issues is worthwhile. And this is a good example of something that, this is a new recommendation for you now. You're 53 and you 20-pack year history. We should do this test on you. If that person didn't come in for an annual visit, it might not be done. So,
anybody out there listening know the difference between an annual wellness visit and
a physical?
A physical?
I know the difference.
I know, but do the patients know the difference?
You know what I tell patients? I say, you're right. It's not the same thing. But you know what? It's close enough. And I have very little resistance from my patients. Once you kind of explain that the thing about a Medicare wellness visit is you don't have to do a physical, but you could. And I do a little bit of a physical, and I do it for a couple of reasons. One is every now and then I do find something, like AFib. Listen to someone's heart, it's a little irregular, but now you do an EKG, they're an AFib. And the other reason is just they taught us this in med school. That contact, really kind of helps reinforce the doctor-patient bond. That's something that you can't measure, and despite kind of lip service to the contrary, really, doesn't get valued as much. So especially in older patients, they really need that. So I get very little resistance from patients. What sometimes comes up is what if you're doing more than just the wellness visit? What if we're in the physical? What if someone brings up a problem like depression or shoulder pain, or maybe they're having a cough? Now you're doing stuff beyond what's being done in a regular visit. Or what if you're just kind of following, hey, here's your diabetes stuff, your meds we got to adjust your meds. You're doing more than just the wellness, and sometimes that might generate a separate bill, which might have a copay, and that can lead to tension and frustration. Because sometimes the Medicare wellness visit specifically is advertised as free. I guess it is free, but if other stuff are addressed, it might generate a copay.
Right. You're saying the word free with little quotes around your face. I know we're on the radio, but it's covered. I mean, I don't know. Is anything free? So it's covered.
And it's actually one of the classic disconnects between the doctor and the patient. Kind of my agenda versus their agenda, and that kind of push me, pull you that can kind of occur in during a visit, and there's an art to it, but
I would always say to patients, their doctor wants to see you once a year when you're feeling fine.
That's a good way to say
when
it.
You didn't sprain your ankle, or you don't have an ear infection, or your throat doesn't hurt. They want to have you come in and see you when you're well, to keep you well, and that seemed to be a pretty good explanation.
Yeah. I get a little resistance from patients. I think wellness visits and physicals are good. There's some misconception out there. There was a study a couple of years ago which decided that a physical exam was not necessary. And I think that study did a disservice. Yes, a traditional, as Seinfeld would say, take off your clothes, sit on the butcher paper in the cold room for half an hour, wearing that thin drape while the doctor decides to finally come in. It has not been proven to be of value, but there's other stuff that is of value that would be done in that visit, and that's what's important. Counseling is very important. I have patients that maybe they're 35. Look, I want to counsel them now. This is let's take care of you now. Let's keep you keep you exercising, keep you eating well. Look, you're smoking. Let's try to get you to stop smoking. You're probably, drinking too much out. Really that kind of behavioral intervention that we know has value, but at the same time is hard to value. That makes sense?
Yeah, it makes perfect sense.
So I call it, and sometimes I call it to a hello visit. I say, come say hello to me once a year. What's it hurt? What did it hurt you to say hello? Little Jewish guilt thrown in there.
So what else besides the lung cancer screening?
All right.
Which you're highly recommending.
Yes, I am. And, there was the insurance companies, surprise, surprise, were dragging their feet on covering these things. But I think they've come around.
What about the cardiac calcium score? Is that getting covered now?
No. It's interesting.
It is interesting.
A couple things make this interesting, okay? One, by the way, I will go to segue. Well, not segue, but it's not funny. So when people get this LDCT, the radiologist is going to look at the lungs, but also note other things that they might see. And one of the things that I've seen many patients reported are calcifications in their heart. Calcifications can be a marker of heart disease, blockages. So this is quite common, because who's kind of getting these things? Well, maybe, a 65-year-old, So in addition to making sure they don't have lung cancer, guess what? They might have heart disease. So a couple patients have had to have a cardiac workup. I can't ignore this, this finding. If they've already had the workup, okay. But if they haven't had the workup, they should. The workup is a stress test. So in one case, a man ultimately had to have a stent placed. It was very serendipitous that he had this test done, and because he wound up. And then, I guess now that I think about it, I am feeling a little bit of this, a little of that. You see that sometimes, because people come in all shapes and sizes. Some people will magnify their symptoms, and other people will minimize them. I'm fine. Well, then you have to kind of pull it out of them that there are some things, and usually the spouse is going, That's a visual. But the spouse is sitting behind, how you doing, Mr. Jones? I'm fine. And the wife is behind shaking her head, no. Okay, so that's kind of one side effect of. And what else? You also get, with these CAT scans, you'll get a look a little bit at the aorta. So the aorta might be dilated. That's called an aneurysm. Aneurysm screening is its own is a category as well. Excuse me. So what was your question?
Well, when we had Dr. Christiana on, he's a cardiologist right here in Kingston, he said that the CT calcium score, I remember specifically sitting right here in the chair saying that the CT calcium score tells him more about your heart health than any other test that he does. Anything else, even the nuclear stress test and all of these other cardiac tests, which he values. He said, they all have value. But this particular CT calcium score, which is kind of a low, it's a CT scan, kind of like
also it's a CAT scan, yes. I'd have to ask a radiologist if it's the same dosing as an LDCT, the lung cancer screening. No, you're absolutely right. So, the Medicare, Medicaid, insurance companies are going to wait for the evidence. They're going to wait for something to be proven, and if something's never been proven, they're not going to cover it. It doesn't mean it shouldn't be done per se. It's kind of like, what was the old Trident commercial? 4 out of 5 dentists recommend Trident gum, right?
Yeah.
That 5th dentist was like, no, bazooka all the way. But anyway, if cardiologists are all saying, they want this test because it's going to help them take care of you. So what another thing that's interesting about this test is by getting the third party out of the system, it's brought the cost down.
Yeah, the cheap test is like $75.
Yeah, so, this whole, when people really analyze healthcare and how it kind of got in this spiral of more, they will frequently blame the three-party system, kind of like just kind of circling around and around, and each circle kind of getting bigger. And here's a good example. What happens when it becomes just something that a patient may have to pay out of pocket? In addition to the patient deciding, the cost came down, Anyway, I find that very interesting. But calcium scores are a good way to assess your risk of heart disease. If someone, for example, is pretty healthy, but maybe their father had a heart attack at 55 and now they're 45 and they want to make sure they're okay, calcium scores is a good thing. But what are you going to do with the results? Usually it's risk factor modification. And if you're smoking, we got to get you to quit smoking. If you're sedentary and overweight, we got to get you to be more active and lose weight. It's usually, depending on the level, an indication to give you a little cholesterol medicine. Because remember, cholesterol is one of the major risk factors of heart disease. So sometimes I do the calcium score for that. Hey, your cholesterol is high. I think you probably should be in cholesterol medicine. I don't want a doc, and I say, well, let's, maybe a calcium score will help us sway us one way or the other. And if that's what the patient chooses, well, I'll order it, and if it comes back elevated, the patient at that point might agree to go on a cholesterol medicine.
So that's what you're seeing is like crystallization or calcification in the blood vessels?
Yes.
And that's caused by cholesterol?
Yeah, the plaques, blockages, and they got many things in there. Cholesterol is a big part of it, but also just calcification will occur as well. Sometimes you see calcification just on an X-ray, calcification of the cardiac vessels. It's interesting, or the aorta. But no, the calcium score could be helpful.
You recommend it?
Yeah, I do. Again, it's an expense that someone might want to incur, but I think it's a reasonable thing. If you're 50 and you're worried and you got family and you want to make sure you're okay and going to be around for them. Maybe your father passed away at 55 or whatever. I think it makes perfect sense. Women too. I think my examples are always talking about the father passing away, but remember if you have a first degree family member male family member who had a heart event that's 55 or earlier, that increases your risk, or a female relative at 65 or younger. But again, if someone says my father died at 56, I'm not going to sit there and go, oh, don't worry then. These are just kind of all right. We got a break here. We were yammering.
Thank you, Dr. Eric Stamberg and Robin Baker. And it's now at the bottom of the hour at 8:30 a.m. this Monday, November 8th. And this last portion of Kingston Community Radio was underwritten by Sawyer Motors, Bob Circusano, and the whole Sawyer Motors team on 166 Ulster Avenue, Saugerties, New York, 12477. Go visit them and their phenomenal inventory. 845-247-5027. 845-247-5027 if you'd like to call them. Because the colors and quality of paint you choose matters, Herzog's Paint and Design Center, located in the Kingston Plaza, is there for you, offering the largest selection of Benjamin Moore paints and the area's most complete line of painting supplies. From Benjamin Moore Paints, including the eco-friendly Aura line. Color decorating consultants and expert interior designers are always there, ready to assist you in all of your home design and building needs. We'll be right back.
Everyone is talking about healthcare these days. America spends twice that of other developed countries on our healthcare system, yet our health ranks near the bottom. How can we stop spending so much and getting so little? By shifting to a system that gives more patients access to strong primary care. Primary care can help make America healthy again. To learn more about the benefits of primary care, visit www.healthisprimary.org. This message is brought to you by America's Family Physicians.
Never completely ready to adopt a teen.
For late nights writing English papers.
For your teen's music taste.
For dinners, where they talk more on their phone than with you.
For the first time, they call you Mom.
You're never completely ready to adopt a teen, and you can't imagine the reward.
To learn more about adopting a teen, visit adoptuskids.org.
Brought to you by the U.S. Department of Health and Human Services, Adopt U.S. Kids, and the Ad Council.
Hi, this is Cameron Rylance from Kingston, and I support Kingston Community Radio because it's informative.
And we're back, and thank you for being with us here at KCR, Kingston Community Radio, WGHQ, AM 920 and 92.5 FM. And we have a pretty nice, consistent lineup for the weather. Lots and lots of sunshine today with a high of 61. And Monday night, clear skies, a low near 35. And 61 degrees again on Tuesday with a lot of sun, a few clouds. And Tuesday night, cloudy with a low of 43 degrees. And Wednesday, a few passing clouds, otherwise generally sunny with a high of 61 again. And Wednesday night, a few clouds, low of 31. This upcoming portion of Kingston Community Radio is brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley, one near you. Let's get back to the on-air studio with Robin Baker and Dr. Eric Stamberg.
All right, thank you.
What's that number?
331-9255.
That's right.
That's right, the door is closing. All right, this is our final segment of this morning's show. I wanted to talk a little bit about COVID because, but there's been some interesting developments regarding treatment. Now, remember, we still want the vaccination. I think I heard that the adult vaccination rate in the country is about 70%. Okay, but these are treatments. So the goal is to prevent the illness, and that's going to be done by vaccination and to varying degrees other controls like mask wearing and distancing, depending upon the recommendation of where you reside. But there are two interesting things that happen. One has to do with Pfizer. Pfizer is one of the pharmaceutical giants. Has been studying a specific medication that's called a protease. Proteases interfere with an enzyme that is very important for viral replication or replication. So proteases have been amazingly effective at helping treat HIV. protease inhibitors. Let me clarify that. So protease inhibitors have been amazingly effective at helping treat HIV, for example, turning HIV from a fatal illness to a chronic treatable illness. And it's also involved with Hep C now. All those hepatitis C treatments that you see in television involve protease inhibitors. Well, it turns, and we have been using one in the hospital setting called remdesivir, but Pfizer has been studying another one. It's got a long name. It's mupirinavir, I believe, and this was first identified around 2002, 2003 when we first had our SARS pandemic. It's been that long. You remember that? And it was kind of researched, and it's been a little bit of what's called an orphan drug since then, not really having a role. And then, understanding the business of pharmaceutical research, they love it when they can find a role for an orphan drug. There's some other examples. We don't have to go in them now. But so Pfizer has been studying the effectiveness of this medication on people with COVID. And the results were so dramatically positive that they ended their study. The idea of the ethics in medicine and ethics in studying medications. If you're studying something and the results are so overwhelmingly positive, remember you have to have a treatment group and a control group. So you're giving treatment to one group and you're not giving treatment to another group. So if the results are so overwhelmingly positive, it's unethical to not give the treatment to the control group. So sometimes a study will be ended because the results are already there, and it doesn't become ethical to continue it. So they found with this medication an 89% decreased risk of hospitalization of death. And that's a little bit of a game changer. We'll see if this becomes kind of something that can be commonly prescribed. My guess is, just because this kind of came out. By the way, it also caused Pfizer's stock to jump 10%. But I think this is going to be a little bit of a game changer for treatment for COVID. Another thing that's very interesting is an antidepressant. We were talking about depression a little bit today. Fluvoxamine, which is also called Luvox. Drugs sometimes have different effects, and that's why they're used for different reasons. For example, think about acne treatment. A lot of times people with acne are prescribed a topical antibiotic. It turns out that antibiotics have kind of some, as far as the skin goes, some anti-inflammatory properties. Acne, for example, is not just about treating the infection. It would be a lot easier to treat. We just put all these teenagers on penicillin and they would get better, So anyway, the point I'm trying to make is that medications have different roles. Well, this fluvoxamine turns out to be very anti-inflammatory. And studies showing this have been promising as well to minimize symptoms and help minimize hospitalizations and fatalities. And that almost makes no sense. But it's, again, when we talked about hydroxychloroquine and ivermectin, two medications that were commonly debated, I said, let's study it, before we start doing it. Well, in the case of fluvoxamine, it's being studied. And so far the results look positive, promising. Interesting. I have no idea why an antidepressant would help with that, but it apparently has other anti-inflammatory properties.
Great. That's awesome.
So the COVID news in our community is about kind of the same. People are getting their boosters. I have not seen as much. I haven't really been working urgent care for a couple of weeks. That's, but in my practice, I haven't seen as much. But there still are cases, and it's still a concern. People who have not been vaccinated. Again, the booster's well and good, okay, and people should get the booster. But the more pressing problem is not that. It's people who have still not been vaccinated in our community. Measles is a great example. Measles is very contagious. So you really need, take a college where young adults where measles can still show up. And I remember before COVID, you and I would talk about measles before we would talk about, because it was in the news, right? I think New Paltz had an outbreak, or maybe Bard or something. So if the immunization rate of measles dips below 90%, it will show up. And then it will go throughout the community, including people who've been vaccinated. So you really want to keep that vaccination rate high. And COVID's kind of like that too. So even though 70% of the adults are vaccinated, we still want a higher percentage. We don't know that number yet. Remember, measles vaccine's been out since the mid-'60s, so we know, we can give you a better idea of that number. Plus, it varies from region to region. Some states are just not as highly vaccinated as the others, and that 5% difference can make a big difference in how it's affecting your community. I'm still amazed at how the state of Texas has basically the same number of fatalities as the state of California. And to me, that evidence is just overwhelming of the benefit of vaccination versus not. Remember, first of all, California's numbers are skewed because they got hit hard early, just like New York. So by the time it kind of started to hit Texas, prevention was supposed to be in place. And Texas has about 70% of the population of California, so therefore they should have about 70% of the fatalities of California. But they're about the difference about 500 individuals now. They're virtually pretty close to a tie, and as the rate increases, I think Texas will pass California probably within the month. I just find that amazing. What do you think?
Yeah, it is.
Well said.
Thanks. I don't know. This is a topic that's hard to talk about. So,
you still know people who haven't been vaccinated?
Yes.
Yeah. Without getting into details, I mean, what's going on? They just don't think they need it. In a way, they're kind of coasting on us.
Well, they don't believe.
They don't believe. Really, they just come out and say, "I don't believe."
Or they had COVID and they think that they're, just like, well, I had the chicken pox, so I'm immune.
Yeah.
And it's hard to explain that, like, one thing doesn't equal another. Like,
right.
It's proven that just because you had COVID doesn't mean that you're not going to get COVID again.
Right. There are plenty of people who've gotten it a second time. Some things, there is some truth. If you have COVID, you're probably protected for about 3 months. That's why we generally tell people who have not been vaccinated to get vaccinated 3 months after they've had the illness. You probably and hopefully will have a more mild case because there'll be some remnants of antibody floating around in your body. But again, first of all, we're trying to minimize transmission as much as possible. And people who've had COVID still getting vaccinated will be less likely to get it, which means they'll be less likely to go throughout a community, which means they'll be less likely to make people seriously ill and succumb to it, and also more likely that we'll be able to get back to our normal lives. So, and we don't really know what level is considered good enough. I don't even know how to order the level of a COVID response. I can order antibodies, and I really don't want to. I said to a patient, look, if it's going to help you decide one way or the other, I guess I'll order it, but I really want you to understand that I think you should get the vaccine. I said, I don't want there to be any confusion about this. Because I hear people say, my doctor told me I didn't need it. Well, I don't want that to be me. I don't want that person to be at some, family get-together at Thanksgiving. By the way, Thanksgiving's coming. And that was when things, one of the times when things got bad. It was the beginning of a rough winter. Thanksgiving and then Christmas. People indoors. We didn't have the vaccine yet. The predictions were true. By January and February, things were out of control.
I've also had people talking about their doubtfulness of the testing. They think that the testing is not accurate, that there's the false positives and then the false negatives. And they don't know why the testing can't be more accurate. And so then also when there's an asymptomatic positive case, someone's positive for COVID, they have to quarantine, they don't have any symptoms at all. Nobody else in their whole family got COVID, so everyone else is negative. So are they actually positive, or is that absolutely, not correct? But I don't know. I've found, with the office and with, knowing you and everything I've dealt with medically, there are just no absolutes. There's just, is there ever something that's like, I don't know, absolute that you can
Well, first of all, like with the home pregnancy test, true false positives are very, very, very unlikely. There are a few tumors, for example, that secrete HCG, which is the pregnancy hormone, which people don't want to have. But generally, if that pregnancy test is positive, you're pregnant. So if someone has a positive COVID test, it means at some point there was COVID living in their nose. You're right. Maybe it's left over from a month ago. But at some point it was there. And
so that was like an issue, like the absolute, like they can't believe it because it's not accurate.
Whenever you do a test, you're right. You're swabbing the nose. Maybe you just didn't swab enough. Maybe so you might miss the sample. So false negatives are a concern. That's why a lot of times we will follow up the
rapid test with a PCR.
With a PCR, yeah. No, I really think that's highly, highly, highly unlikely. If someone's positive, at some point COVID was in your nose. It's really. That's the way I view it. So you're right. Doesn't mean it's actively in your nose. Doesn't mean it's enough there to put other people at risk. We don't really know that, and that's why we recommend that you quarantine, regardless of how you feel. So
err on the side of caution.
Yeah. So the tests for positivity are pretty good. Tests for negativity, you're right. The rapid test particularly can miss some cases. And is it possible maybe the test will continue to be refined? I guess so, but you can say about anything. When I test someone for strep, there are times where I do a rapid strep, and in the office it's negative, but for whatever reason I'll do a more traditional send-out culture, and it will come back positive. That happens. It depends on the case and whether or not we decide that it needs that next step to make the diagnosis.
Do you know people who haven't been vaccinated?
Not really. I have some patients, yes, and that can be quite frustrating because I think they're putting other people at risk by being in the office, unfortunately, and that does concern me.
Did they offer their reason?
Yeah. Well, when I ask, They vary from people just saying they never go out. They're not going to get it. I hear that one. That one always makes me. I'm like, well, you must go to the supermarket. You must go get gas, and you're here right now. So obviously you go out, and even if you don't go out, someone might come to you. There were so many examples of like people, homebound patients who got COVID because their caretakers brought it to them. So I think that's very faulty knowledge that you never go out, and I would discourage someone to use that as a reason to not get the vaccine. Some people, some of them are really just non-believers in it. The one that sticks out is the one who didn't want the vaccine but wanted me to prescribe ivermectin, and that was very frustrating to me because if you just look on the pure level of science, the vaccine has science behind it, whereas ivermectin is being studied. That's a nice way of saying it, but right now there is no science behind it. Although I will be open-minded if somehow it reveals to be a decent treatment. But I think you're really making the wrong decision if you're choosing not to get vaccinated, but then taking ivermectin. You're not following the common knowledge right there. You're following other stuff. I think a certain football player got himself in trouble for that.
Yeah, it was in the news.
And I believe his team lost yesterday.
It was sad.
Yep. Who knows if they might have won if he was able to play the game.
Yeah.
So what other reasons the vaccine? Yeah, they're again, people are kind of not making sense. They didn't like the it wasn't approved right. It was, and I have defended that feeling. I think it was a little confusing. It was not approved. There was emergency authorization. It's kind of like a semantic argument there. But you know what? They've all been approved now. So there were people who were saying, I'm waiting for it to be approved. Well, it's approved now, so go get it. What else? The vaccine has been out since December, so we're inching up on a year. And, we should talk about that because there are people will say there's reports of fatalities. Okay, so if someone gets the vaccine, remember this is a big country, 330 million people, 340 million people, who knows, and things happen. So someone gets the vaccine and 2 days later they have a stroke. Does that mean that the vaccine caused the stroke? So this generates a report. Well, someone's concerned enough and they report it to the CDC, and the CDC will kind of put it in the data bank and review it. A good example was the Johnson & Johnson vaccine, where there were reports linking it to clots and it was temporarily taken off the market and then kind of put back on the market. I did read an article over the weekend that the J&J vaccine does potentially have a higher rate of causing clots, but still at a much lower rate than COVID has of causing clots. So, that being said, if patients ask me what vaccine should they get, I do say the Moderna. I think the Moderna is probably the best choice right now. And then, by the way, the boosters kind of mix and match. So if you had the Pfizer, you can go. The Moderna is kind of being recommended for everyone. It showed the best benefit in the context of a booster. Pediatrics, it was approved for 5 to 11 over this past week. The Pfizer vaccine, it's kind of a lower dose.
Approved for pregnant women?
Yes, and that's not new, by the way. Yes, it has been approved for pregnant women. Pregnancy puts you at risk of many things, So to get COVID while you're pregnant or postpartum puts you at higher risk of having a more severe infection. So where does that leave us? It's kind of, you and I talk about that every week. People should just kind of get vaccinated. If you know people who have not vaccinated and you're agreeing with us, which I hope you are, you should kind of continue to nudge them. Sometimes tough love has worked too. A family has a newborn, and the grandparents say, well, I didn't want to get the vaccine, but my daughter won't let me visit the grandkid until I get the vaccine, so I guess I'm going to get it. I'm like, all right, that works. I'll take it. Same thing with people with their jobs. My job's making me okay. Again, whatever. Mm-hmm. But it's still a concern, and I'm nervous about Thanksgiving hitting us again because they predicted this last year. If you remember, get-togethers at Thanksgiving and then Christmas. The family get-togethers, enclosed areas. We never saw the flu spike that we thought we were going to see, which is interesting, and to me that just shows you how much more contagious the COVID virus is than the flu virus. Mm-hmm. Because these preventive measures like mask and distancing kind of prevented a flu season, but certainly didn't prevent the COVID season.
Right.
Might have mitigated it. Might have been a lot worse if we didn't have these. Well, it would have been a lot worse.
So if you're planning on having a Thanksgiving get-together and there's somebody in the group that's not vaccinated, I don't know. I'm going to, in my own personal life, I'm going to insist that they get a negative test.
I think you should disinvite them, okay? I understand that's a tough decision.
If they choose to be not vaccinated, then they're going to have to be tested.
Right. And I would recommend a test within 2 to 3 days of Thanksgiving. There's testing you can get at the pharmacy now.
Yeah.
But I think that ideally they should be uninvited. I think that even if I don't know. People say, "Oh, it's a personal choice." It is a personal choice, but personal choices have consequences. If the consequence of your choice is that your job is going to let you go, or the consequence of your choice is that
you can't go to Thanksgiving.
You can't go to Thanksgiving. That's the consequences of your choice. So, I want people to use this as a time to maybe get vaccinated. I had a patient who had COVID. In her mid-30s, and she works with a special needs population. And she said, I think I'm going to get the vaccine. And I said, good. I think you're right. She says she doesn't want to get it again, and she doesn't want to be responsible for transmitting it to the people she takes care of or to other people. I said, well, that is very admirable logic. I wish she'd gotten the vaccine to begin with, but she didn't, which is, and she was quite ill, but she didn't have to be hospitalized. There was a fatality to COVID over the past couple of days in the hospital. So it's people are still succumbing to it. A woman in her early 70s, not vaccinated. So keep that in mind. So, Robin, we should also briefly remind people that it's not flu season yet, but flu shot season.
Mm-hmm. And
I think, people have been pretty receptive getting the flu shot in my practice, and I appreciate that. You get yours yet? You got to get yours.
Yeah, no, I haven't.
I had mine.
Yeah.
I had a bad side effect. It made me funnier for about 3 days.
Yeah, for about 8 hours. I woke up and I was like, why am I not feeling good? In the morning, it was like, why am I not feeling good? It took me till about 3 o'clock in the afternoon before I started, rousing back into normal Dan. It was kind of weird. It was obviously the flu shot taking hold and doing its thing.
Yeah, and I didn't have any side effects to the flu shot. I had a friend who had the COVID booster who did report a rough day after the COVID booster. So I will be getting my booster shortly, and I will try to arrange it at a time where I can, potentially relax the next day if I'm not feeling well.
Yeah, definitely. And they say you can get the flu and the COVID vaccine at the same time.
Yes.
Maybe I'll just do that.
No, that's a good point. When the COVID vaccine first came out, again, it was new, and we wanted to make sure it was effective. So we did recommend that you not get it within 3. Oh gosh, I can't remember if it was 3 weeks or 3 weeks of another vaccine. But that's not the situation anymore. You can get your flu shot and your COVID shot in the same day. This time of year, it's also a good time for people to review that whether or not they've been properly vaccinated against pneumonia or pneumococcus. A lot of people bringing up the shingles vaccine. The shingles vaccine now, the coverage is improving, and we're really advocating it for people 50 and up. That's a lot of people who potentially should get the shingles vaccine.
Is the Shingrix vaccine once and done?
Yes.
Okay.
It's actually 2 doses. Okay, and then.
Oh no, it is. Yeah, absolutely.
Yeah.
Within like 6 weeks or something.
Now things change. 10 years from now, maybe they'll say, "Hey, immunity is waning, and we recommend a booster." I mean that happens, but yes, for now it's 2 doses and done. Hey, I had the shingles vaccine a couple of years ago, and 3 or 4 years ago. It did make a lot of. My arm was quite sore for a while. So there are side effects. Doesn't mean they're not good things to do.
Yeah.
The shingles vaccine is about 50% effective, so it doesn't sound great, but it really does mitigate the other 50% as well. So that's another point to remember. We want to prevent the illness. We don't always prevent the illness, but frequently we do make it more mild. The same thing can be said of the flu vaccine. So.
Right. What do you say to people that say they got the flu from the flu vaccine?
Well, this is what people say, right? One more minute. You can get side effects from the shot. Dan just described his. He didn't get the flu from the shot. He had side effects from the shot. You can get a cold that has flu-like symptoms. That's not the same thing. You could still get the flu, but the flu shot does not cause the flu. Hard stop.
It's physiologically impossible.
Physiologically impossible. It's an inactivated virus. But you're right. People are confused. If it doesn't cause the flu, how come it could still make me a little sick? So I can understand that that's kind of a little contradictory there. But having side effects from the shot is not the same thing as having the flu from the shot.
That's like an immune response, like it's
right,
your
that's
immune
your body
system
responding.
kicking.
Yeah, a lot of symptoms of an acute illness are caused by the immune system. Fever, for example, is a great example. That's the body kind of fighting the infection. Anyway, we're going to I'll call it a week. It's been a vibrant conversation. Would you say that, Robin?
Yes, I love our conversation.
Okay. All right, everyone, have a good week. I hope you enjoyed the show. We'll see you back next week.
Thank you, Robin Baker, Dr. Eric Stamberg. And it is now 8:59 a.m., and you're with us here at KCR, Kingston Community Radio, WGHQ AM 920, 92.5 FM, and our live streaming on mykcr.org. Monday, November 8th, 34 degrees. This last portion of Kingston Community Radio was brought to you by Ulster Savings Bank. Many locations throughout the Mid-Hudson Valley, one near you. Until tomorrow, Tuesday, for a terrific Tuesday, we wish you every success in growing and developing Kingston and all our neighboring communities. We now return you to Magic 92.5.